Welcome back to our 15-part Evaluation and Management Training series. Look, if you're a certified coder, an auditor, a biller, or a CDI specialist, you already know that medical decision-making can sometimes feel, well, a little subjective. But today, in Part 8 of our explainer, we're zeroing in on MDM Element 2, the amount and complexity of data to be reviewed and analyzed. We're going to treat Chart B scoring like a strict, objective mathematical formula. No more auditing guesswork, just straight logic.
Here's our game plan for today. We're going to decode the Chart B categories, build out our scoring equations from minimal all the way up to extensive, run through some rapid-fire drills to test your skills, and then wrap up with some absolutely crucial auditor best practices.
All right, Section 1, decoding Chart B categories. You can't solve the math if you don't know what your variables are, right? Before we crunch any numbers, we really need to nail down a couple of elements that honestly trip up even veteran auditors: the independent historian, or IHX, and the independent interpretation, or INTERP. An independent historian is someone, maybe a parent, surrogate, or witness, providing necessary history alongside the patient. Usually this happens when the patient just can't provide a complete history or a confirmatory history is medically necessary. Now, an independent interpretation, that literally means analyzing a test another provider performed, and crucially, it has to be a test with a CPT code that you aren't separately reporting.
I love how elegantly this data groups into three distinct buckets. Think of these as your three main variables. Category 1 is all your standard tests and documents, reviewing external notes, checking out unique test results, or ordering unique tests. Category 2 is entirely dedicated to your independent interpretations. And Category 3, that's all about external discussions, meaning discussing management or test interpretation with an external physician or appropriate source. Literally every piece of data a provider reviews is going to drop into one of these three buckets.
Moving right along to Section 2, let's look at scoring minimal and limited data. The logic here is incredibly straightforward. For minimal data, if a provider reviews 0 or maybe just one test or document, they stay right there at minimal. But to bump up to limited, you only need to satisfy one of two specific categories. You could find any combination of two items in Category 1, like, say, ordering a lab and reviewing an external note. Or, and this is a big or, completely separate from those standard tests, you could just have an assessment that requires an independent historian. Hit either of those criteria, and boom, you've scored limited data.
Okay, Section 3, calculating moderate data. Let's turn up the dial and escalate that complexity.
So what does it take to hit moderate? The magic rule here is that you must meet at least one of the three available categories. You can do this by combining three items in Category 1. So ordering two unique tests plus using an independent historian equals three items. That checks the Category 1 box. But take a close look at Categories 2 and 3. You can bypass Category 1 entirely. If your provider does just one independent interpretation, that satisfies Category 2, landing you at moderate. Or one external discussion satisfies Category 3, which also gets you to moderate. You just need to check off one of the three boxes.
Let's move to Section 4, reaching extensive data levels. This is where things get really interesting for auditors.
The jump from moderate to extensive is a simple but incredibly strict rule change. For moderate, you only needed to satisfy one category, right? Well, for extensive, the documentation has to satisfy at least two of the three distinct categories. You can't just pile up 6 different blood tests in Category 1 and try to call it extensive. It doesn't work that way. You actually have to mix and match across the different categories.
Think of this as your cheat sheet, the master combination matrix for extensive data. Notice how combining an interpretation from Category 2 with a discussion from Category 3 perfectly satisfies the rule? You might have absolutely 0 standard tests or documents, but you still hit extensive. Or you could pair 3 Category 1 elements with a Category 3 discussion. As long as you are successfully checking off 2 entirely different category boxes, you're looking at extensive data.
Section 5, theory is great, but application is everything. Let's do some quick-fire scoring drills to really lock this in. Grab a mental notepad.
Scenario 1. You're auditing a chart. The provider reviews one unique test result, and they utilize an independent historian to confirm the patient's symptoms. Take a quick second. What's the score?
If you said limited, you hit the nail on the head. One test plus one independent historian gives us a combination of 2 total items. 2 items perfectly satisfies the requirement for a Category 1 limited score.
Okay, let's step it up a notch. Scenario 2. The documentation shows 2 ordered tests,
plus one independent historian, plus an independent interpretation of an image performed at an outside facility. What are we thinking here? That is extensive. Let's break the math down. 2 tests and 1 historian add up to 3 items, which totally satisfies Category 1. Then, that independent interpretation satisfies Category 2. 2 out of 3 distinct categories met? Yep, we've reached extensive data.
Final drill. Scenario 3. Your provider independently interprets an MRI performed elsewhere and then discusses the patient's management with an external specialist. There are 0 basic labs or notes reviewed here. What is the level?
Extensive again. See, this is exactly why we trust the formula. Even without a single Category 1 test, the interpretation handles Category 2 and the discussion handles Category 3. Hitting 2 out of 3 categories instantly grants you extensive data.
Section 6. Auditor Best Practices. Knowing the formula is fantastic, but plugging bad data into it, that's an auditor's worst nightmare.
Here are your golden rules for compliance. First off, absolutely do not double count overlapping elements. For instance, a CBC with differential inherently includes a basic CBC, hemoglobin, and a platelet count. You can't count those as 4 separate things. It's just one unique test. Second, strictly verify the medical necessity of an independent historian. They can't just be acting as a translator, they have to be providing a medically necessary confirmatory history. Third, are you absolutely sure that discussion was with an external provider? It can't just be a chat with the nurse down the hall. It has to be an external qualified provider in a different group practice or specialty. And finally, tests ordered outside of an encounter only count for points in the specific encounter where they are actually reviewed and analyzed by your provider.
Mastering Chart B and these data combinations takes the guesswork entirely out of your audits. But the medical decision-making puzzle isn't complete until we tackle the final element, patient risk. I mean, if a patient has minimal data but a massive medical risk, how is your audit going to hold up to scrutiny? Join us right back here for part 9 of our explainer, where we will break down MDM Element 3 to find out. Keep practicing those combination drills, stay compliant, and as always, decode healthcare with Harshal.